I just wanted to present some data that we have put together over 2 years and some comments about it. This is some, over a 2-year period, we looked at all first trimester screens that we had done at Women's Imaging. These were people that had come for both nuchal translucency assessment and just for first trimester anatomy. There were 2,051 fetuses, of which there were 34 twin pregnancies. Our population is a low-risk population. There are on average 32 years, and our NT distribution was satisfactory, meeting the College of Ranscog's criteria for satisfactory use of NT. We also looked at the 20-week scan of the fetuses that we had seen in the first trimester, of which there were 1,576, or about approximately 3/4 of them came for follow-up 20-week scans. We found 22 anomalies in the first trimester, which is, of the number scanned, 1.07%. We found 15 anomalies in the second trimester scan. And when I say anomalies, I have used a definition of major anomaly rather than including major and minor anomalies, which is kind of important as we go forward. So we had a total of 37 major anomalies, and we detected 59% of these in the first trimester. All of our scans have both a TA assessment and TV as required. We capture steels and cine loop. All our machines are 3D capable. The scan takes about 45 minutes. We have a mixed group of sonographers. They're all NT and MB certified, and recently all are DV and UTA certified. And it's a supervised scan. This is our worksheet, which is a fairly simple one. It just requires some ticks in the box. These are our data, and the 2 columns here refer to, this is the high risk, this is the major anomaly group, and this is the minor anomaly group, and you can see the number. We've decided to put multiple anomalies as 4 cases. Some groups separate out each of the anomalies, of which there may be up to 5 in each case as a separate individual anomaly. We decided not to do that. This is the second trimester anomalies. These are major and these are minor. We've included the aberrant right subclavian and the left and right SVC as anomalies, and the right-sided aortic arch. There's a lot of discussion about whether they're anomalies or whether they should be in the normal group, but most people will put them in the minor anomalies. When we compare ourselves, it's quite a problem with anybody that reads obstetric literature. Everybody makes separate definitions of majors and minors and etc. Ours is and we are in a low risk population, so I'm not sure how we compare to King's in London because they have a high risk population than we do. We have a small number. We also have incomplete postnatal follow-up. There were 25% of the first trimester scans that were not scanned by us for the second trimester. It's a small town, we kind of know, but still it's incomplete data. When we compare ourselves to the larger groups, we can see that with a detection rate of approximately 60%, we're well within the expected range, and we've detected about the number of anomalies. When people have divided the first trimester anomalies, they tend to divide them up into 3 groups. And there are those that are always detected, and that's about 30% of them. There are those that are sometimes, and those that are never detected. And the never detected group are a reflection of the fact that some of the abnormality has not happened yet. The brain is very underdeveloped, so vermian agenesis, or if you believe in it, hypoplasia, will never be detected. Echogenic lung lesions are rarely seen before 16 weeks because of the physiology related to lung development. Likewise, the renal abnormalities. Baby is just not producing enough urine. You will see some renal, but not as many as you will see in the second trimester. So when we looked at the always detected group, This is a normal head that we would expect to see in transverse diameter, and this is the normal profile view. And the ones that you tend to always see are the holoprosencephaly and the acrania group. We had 4 acranias. Also involved in this group is the encephaloceles. We did not have an encephalocele in this particular group. The always detected group is the gastrointestinal group. This refers to the omphalocele. We did not have any omphalocele in our 2 groups, which we combined to make our single group, nor did we have any gastroschisis. However, in the paper that we presented 2 years ago when we did our review of gastroschisis, 10-year review of gastroschisis in Tasmania, there were 12 cases that had been scanned in the first trimester. 11 of those were prospectively reported. This is across the state, and 1 was retrospectively demonstrated on the images. So it is a very gettable diagnosis by all of us, really. The always detected group for genitourinary abnormalities, we had 1, which was the megacystis. And in the never detected group, these are some of our 20 weeks. We had 2 fetuses that had echogenic lung lesions. Oddly enough, they were all both posterior in this group and cystic change. And when we reviewed our images in the first trimester for this fetus, we could not see it, nor in this fetus. So this is one of the ones that is a developmental issue. We had 2 pyelectuses noted in the first trimester. This is in the never detected group, and this is the scan, and we take a AP renal pelvis bigger than 1.5 millimetres as being abnormal. That's slightly controversial. And we had a total of 9, of which 3 were regarded as major pyelectuses at greater than 7 millimetres at the second trimester in our subsequent scans. Now we get into the interesting group, which are the sometimes detected. And this is where all the movement forward and the interest is at the moment. We had 1, this is a normal profile, we had 1 in this particular group that was retronathic. The ones that we did not do particularly well with were the cleft lip and palate. We can argue whether we need to do well in that, but in the face, there's been a lot of work done looking at whether we can identify cleft lip and palate. And this is a case that we had, this is in the group. This is the maxillary view here with the cleft in the maxilla going through the hard palate. This is the coronal view with the separation in the lip, and we've got this little step in the maxillary gap step here in the profile. This is the same fetus. And we could perhaps say, and I'll show you some further images, that this was perhaps a miss for us. So people have worked really hard, and there is a raft of soft markers trying to detect cleft lip and palate. The lip is more problematic. People are looking at the prominence of the soft tissue in the upper lip. People are looking at a hole in the hard palate. They're looking at the retronasal triangle. They're measuring maxillary angle. It's a lot of work, a lot of imaging. We're kind of thinking along these lines. This is a direct view of what is called the retronasal triangle. This is the primary palate, maxilla, and the nasal bone. We're looking for an intact primary palate here. We know we're at the right level across the front of the fetus if we're getting a little separation in the mandible. This is not an easy single shot, okay? Is this the way to go? So this is a kind of like a MIP, multiple scans. We can demonstrate here the reflection of the lenses. We're coming forward, we're getting into the primary palate, we've got the gap, and then we're off the front. This will only diagnose a cleft palate. It won't give you just the lip unless we're going to get into the soft tissues at the front. So do we want to do this? So this is the question. We're certainly giving it a red hot go. The published data, which hasn't been really well reproduced by other people, comes from South America, and they were able to detect up to 85% of clefting. We are not there. In our sometimes detected group, this is the second trimester. You can see an abnormality here in the coronal view related to the hemivertebra. This is the first trimester screen. I believe it was there. We did not recognise it. It's important. The sometimes detected group relates to the spina bifida, and in some data that we'll be producing early next year, when we've reviewed our first trimesters, there is only one in our series that was detected in the first trimester, and this was it. And there's an acorn shape to the head. That you'll have to take my word for this. There's a missing at the back here, and here this is a sagittal view, and there's a dip of the skin. This is not a good image, but it's the best we've got, but it was prospectively reported. In the sometimes detected group, and there's been a lot of work on this, it relates to the question of hydrocephalus. There's been some recent published data out of London. They believe they can detect hydrocephalus in 100%. I think that's absolute whatever, because it is an evolving pathological issue. You will detect some of them, but not all of them. And there's been a lot of data looking at ratios of choroids to the size of the ventricles. It is a process in work, I believe. I've put this up here because in the spina bifida group, just as in the looking at the face, there are about 7 soft markers available now in the first trimester for detecting spina bifida. There's many of them. And as the Israelis have said, the best way to diagnose this is to get the coronal view of the spine. Remembering that in the first trimester, our main aim in life is to get the fetus prone. And suddenly we're wanting it to flip as well, and we get this beautiful little view where we're looking for a little bit of a dip in the skin line. That is the best way to do it. The soft markers are very good. We believe that this is the money shot. So this is at the time when we're looking at the nasal bone. It's also on the view for the nuchal translucency. And we've got the midbrain, the fourth ventricle, and the cisterna magna here. People have called this the IT, and in fact we think that it's the ratio of this to this measurement that will be the most successful, rather than just the measurement of the IT as going forward. So potentially the ratio in this view is the thing that will put up the flag. I must go and get my sagittal view of the spine. The sometimes detected group, we did reasonably well with this in our skeletal, and I think this is where we can potentially make up some of our numbers. The good thing about it is that what we're trying to do is we're looking for something that's missing, something in addition, and an asymmetry, which I think we can probably do. This is our radial ray abnormality, and this was our vertical talus in this 20-week scan, and this is the first trimester picture. I put it there to show you, I don't think I would have called it. It's a bit dodgy. But anyway, potentially I think that the skeletal area is the area for us to move forward for. And also, this is our little babe that was the thanatophoric. We've got the abnormal contour to the face here, and we had the very short limbs. And I think you can see from the biometry here they were short. And the rendered image is the one that shows you that this little babe can't put its hand over here onto its opposite shoulder because they're just too short. The group that people are very interested in, the sometimes detected, is the talipes, and we got the bilateral right and the single wrong, and this is the bilateral one with the single images here, and this is the first trimester view we have with the subsequent second trimester where we've got a single limb with talipes, and this is the limb in the first trimester. And this shows beautifully one of the problems of talipy diagnosis is that you've got the uterine wall for controlling the position of the foot, and this little one has straightened it out beautifully in the first trimester and has got it clear from the uterine wall, and we can see it. This is a progressive disease, and maybe it didn't have it in the first one to the second. Cardiovascular, we made a diagnosis of an AVSD that had a nuchal of 3.3, and the complex heart anomaly that we diagnosed had a nuchal of 1.7. This was the hyperplastic left heart with a single outflow tract, and this is the AVSD with the hole in the middle in the first trimester. We had 2 VSDs in this group of pregnancies, both of which had a nuchal in the normal range. We take a 4-chamber view with colour and the 2 vessels for the arrow view as well as part of our routine screening, but I would direct you to the use of the nuchal and the ductus venosus as flags for paying particular attention to it. The other thing that I would say is that the heart measures between 5.5 and 6 millimetres in the 4-chamber view in the first trimester. So, this is all you have to do, and you can make the diagnosis. All right. The problem is that there are false positives, and we don't know what they are. There's little information on these when you look at the literature, and the problem is that many of them are terminated early. This was our false positive. We had a small amount of fluid here in the peritoneal cavity. It's not really a false positive because that's a minor sign, but it is something that we did comment on that caused anxiety, and it resolved. The 3 that are the classics here are the very small omphalocele, particularly those that contain bowel will resolve often. The megacystis will also resolve at under 15 millimetres, and the pyelectasis, it's just a transitory change. So these are the 3 areas that are particularly prone to this problem, but we don't really know what they are. So, how are we going to improve? I don't know whether I want to, but anyway, how are we going to improve? When you look at it, there are non-modifiable factors, and the maternal ones are mum's BMI. The problem with the BMI is that it increases the distance, both TA and their pelvic fat is often quite large, and so it will put the uterus further away from your vaginal scan unless you're lucky and it's retroverted. Fibroids can get in the way. Surgery, particularly those that have had tucks and things, make access very difficult. The fetal non-modifier is that they're small, and the size. Most of our scans are between 12 weeks and 13 weeks. We would possibly do better if we moved them a week later, but then we've got a payoff in terms of the nuchal translucency assessment. So that's an issue. We've got the physiological changes that we talked about in the fetus that restrict us making the diagnosis of the renal and lung problems, and just the straight developmental things where the brain is not developed. We are never going to make that call in the first trimester. The modifiable ones is moving the gestational age, the mode of ultrasound. Vaginal is great, but it adds an extra time and, dare I say it, expense to the study. Every time you do a vaginal scan in my rooms, it's another $4.50 for the consumables involved in that, and you're getting $59 back from the government for this. The time allocated is important. We spend, as I said, 45 minutes, which is generous. Sonographer experience and training is important. Clinicians need to understand the embryology and the markers of disease, and you need to have a standard sequence, and you need to check and audit whether you're doing well in this. So we are attempting to audit ourselves. We have a standard sequence. We're trying to allocate enough time for this, but how much further can we improve? The other rider for some of the things that we diagnose at this stage is, particularly with the spina bifida one, which is one of my areas that we've been interested in lately, relates to the difficulty in counselling a woman based on the imaging findings in the first trimester. The data is available for the second trimester and beyond, and so you can be very clever and find it, but the accuracy of the counselling is compromised by that, and that also flows on to the cardiac abnormalities as well. But people will publish, and there will be more data available to make that a more relevant finding. So thank you. Any questions?